What about physical examination in patient with asthma? So most of the time, especially in between the episodes and when the asthma is controlled, physical examination is basically benign, and there's no much of physical examination findings. But in especially in patients who are having uncontrolled asthma or who have like frequent exacerbations, things to look at. This is a sign of allergic reaction. It's called allergic shiners, and it's basically just like a discoloration below the eye, bilaterally in both eyes, right and left. It could be due to venous congestion because of the inflammation that usually accompany the allergic rhinitis and allergic asthma. So you can see this physical examination finding in patient with allergic asthma, not the other non-allergic asthma patient. And then you also look for skin findings that might indicate also allergic asthma, like skin manifestations of eczema. And in the upper airways, you can look for signs of rhinitis, sinusitis, or nasal polyps in aspirin-sensitive asthma, for example. And also chest contour, again, usually normal in between the attacks and in patients who are having controlled asthma, but there may be like some hyperinflation of the chest, increase of the anterior posterior diameter, and or hunched shoulders in some patients, especially those with uncontrolled asthma. During percussion, if patient is especially in patients who are having hyperinflation of the chest, there might be like hyperresonance when you do the percussion note on the chest exam. And specifically, which might be more useful, is to percuss over the cardiac area. And usually there's some dullness normally in a patient without hyperinflation, but in patients with hyperinflation, that cardiac dullness might be absent in some cases. All right, sound familiar, right? Yeah, this is wheezes, which is the most important physical examination finding in patient with asthma, and a lot of patient with asthma, they know it, and they can provide you this history. So it's mostly expiratory, like you heard here. It's mostly during expiration, less commonly during inspiration, but sometimes could be during inspiration, and sometimes could even be biphasic. But again, most of the time it's expiratory, and if it's predominantly inspiratory, maybe you need to think about other differential diagnoses. It's usually polyphonic, so different musical sounds, and it's usually diffuse and mostly in the lower lung zones bilaterally. So if you hear it mostly in the upper airways or close to the neck, especially if it's inspiratory, you need to think about other differential diagnoses. And patient with focal wheezes, also you need to think about focal pathologies, right? Like maybe there's a mass obstructing a particular lobe or part of the lung, or foreign body, and especially in young patients. So the wheezes does not correlate with the severity. So in the extreme case of silent chest or silent lung, this actually could indicate life-threatening asthma. The obstruction is so severe that it actually almost absent air movement, and there's no creation of sounds or wheezes. So the louder the wheezes doesn't necessarily mean the louder or the more obstruction the patient is suffering from. So keep that in mind. And it's not specific to asthma. We'll talk about the famous phrase, not all that wheezes is bronchial asthma, soon. And there's a lot of differential diagnoses to wheezes. But probably the most helpful physical examination finding in this patient. Now, an important differential diagnosis of abnormal inspiratory sound is stridor, which is high pitch inspiratory sound and usually indicates airflow turbulence in the upper airways. So again, it's usually in the upper airways, not the lower lungs, and it's usually inspiratory, and it's very characteristic. If you hear it once or twice with some patient, then you're probably gonna recognize it immediately. It could be acute, it could be chronic. So for example, in acute stridor, which is an emergency because again it indicates upper airway obstruction, could be due to epiglottitis or anaphylaxis or foreign body. If it's chronic and it's not that severe, it could be it could indicate like other pathology like upper airway tumors or tracheal bronchial stenosis, vocal cord dysfunction or paralysis, and airway narrowing due to an extrinsic compression like thyroid enlargement, for example. So stridor is really important to differentiate from the diffuse bilateral, predominantly distal airway musical sound of wheezes. Some of the physical examination findings that you need to pay attention to, and you're probably is going to encounter these physical examination signs in patients with severe asthma exacerbation or even life-threatening asthma exacerbation. So in this patient, pay attention, of course, to vital signs. Vital signs are vital. So patient with more severe asthma, they tend to have more respiratory rate. They're more likely to be tachycardic, and if their blood pressure is becoming less and less, that's a very alarming sign. Keep attention to the level of consciousness of the patient. Usually with acute hypoxia, the patient tends to have hyperactive delirium with maybe agitation. But when there's accumulation of CO2 or hypercapnia, then they might be actually having hypoactive delirium or drowsy. So patient with asthma exacerbation, if they become drowsier, that's very alarming. And then cyanosis, and sentinel cyanosis is more significant, clinically significant than peripheral cyanosis. Look for ability of the patient to complete sentences, and if they're not able to do that, that's also alarming. Look at the position of the patient, the way they're sitting. If they're sitting hunched over, it could mean that they're trying to kind of expand their chest and wall to get more air and improve oxygenation. Use of accessory muscles of inspiration, especially in the sternocleidomastoid and scalenus muscles, active LNSI, and suprasternal intercostal retractions or recessions. All these are signs of increased work of breathing. Silent lung, we talked about the wheezes and how the severity of asthma doesn't really correlate with the loudness of wheezing. So patient with still having acute exacerbation and they have like less and less breath sounds and wheezes, this could be like an alarming sign as well. It might mean that the obstruction is getting worse. Paradoxical abdominal breathing also. Usually with normal breathing, the chest wall and abdominal wall both go up with inspiration. If the abdominal wall is going down and the chest wall is expanding during inspiration, that could be a sign of impending respiratory failure. So be very careful. And pulsus paradoxus, maybe we'll talk about it in a separate video about this physical exam finding. But when it comes to asthma is one of the differential diagnoses of pulsus paradoxus in addition to other pathologies like tamponade and others, but it's really not very reliable to rule in or rule out severe asthma. So these are much more important, and the overall clinical picture is much more important than pulsus paradoxus.